Hello, everyone, and thanks for joining us. I'm Marion Farage, General Manager of Clinical Services here at Central and Eastern Sydney PHN, and we'll be presenting today's Integrated Mental Health Hub information session. This session will be recorded and made available via TenderLink. The first part of today's session will focus on information about the hubs, followed by an opportunity to answer your questions. Please type your questions in the Q&A box as you think of them throughout the session. You'll also have more time to type questions at the end as part of the Q&A session. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and acknowledge the traditional custodians and sovereign people across the lands that we work. We recognise their continuing connection to land, water and community, and pay respects to elders past, present and emerging, and acknowledge any Aboriginal colleagues joining us today. I also would like to acknowledge people, families and carers with lived and living experience of mental health, drug and alcohol and suicide, and recognise their valued contributions to the work that we do that shapes and supports the systems and services within our region. Central and Eastern Sydney PHN released the tender for the Integrated Mental Health Hubs on the 3rd of September via TenderLink. The tender will be open until the 26th of October 2025. We expect to be awarding contract in December this year and services to be established in the new year with service commencement from the 1st of July 2026. Other key dates are as seen on the slide and are also included in the tender documents. Please note these timelines provided are a guide and Central and Eastern Sydney may vary these timelines following the closure of the tender if needed. During 2022, Central and Eastern Sydney undertook a co-design process with people with lived and living experience and service provider representatives for an integrated mental health model of care. The model was further refined through extensive consultations in May to July of this year. The integrated mental health model of care provides a community-based resource for information, services, and connection for people across a range of mental health needs and situations, offering flexible durations of care, including short, medium, and long-term mental health supports. The hubs are highly flexible and scalable to a range of needs, including for people with more complex and enduring mental health challenges. The Integrated Mental Health Hub is a separate initiative from the Medicare mental health centres and satellites that are being progressively rolled out in each state and territory across Australia. Noting that we only have one Medicare mental health centre in our region based in Canterbury. Components of the model. There are a number of components that we expect to see as part of this model of care. The first being guidance and navigation. Includes offering warm introduction to other services, provides advice and recommendations tailored to individual needs, and is central coordinating point for consumers to educate and navigate service supports. Information and education, which includes resources on psychological, physical, and social emotional wellbeing delivered by lived experience and professional service providers, providing sessions for families, carers, friends, kin, provide several resources including hard copies, visual audio, digital resources, and supports to use and engage with key self-help activities. Assessment and planning. This includes completion of the initial assessment decision support tool, collaboration with consumers in developing wellbeing and recovery plans, supports connections to appropriate services, and support based on individual goals, obtains informed consent from consumers to enable ongoing referral and information sharing to appropriate services. Structured group activities. That includes peer support groups, therapeutic groups, specialised support groups, such as AOD. Group activities enhance cultural expression and traditional practices. Group activities promote physical, creative and social activities, mindfulness-based activities, reduction activities, psychosocial education and skills, as well as group brief interventions. Psychological therapies. Structured evidence-based psychological therapies, regular review of consumer needs to ensure support levels are appropriate and continual feedback to GPs regarding outcomes and further supports. Psychosocial supports include structured recovery-oriented psychosocial supports, flexible support options, connections to agencies and organisations to provide supports in psychosocial domains such as housing, access to NDIS, hoarding, financial assistance, AOD, domestic and family violence, community legal assistance, to name a few. Care coordination. Coordinate multidisciplinary input and team communication, support transitions, liaise with GPs, specialists, local health district providers, provide relapse prevention, safety and safety planning, non-clinical care coordination such as supports engaging with other services and aiding in navigation systems in culturally and or trauma-informed ways, and assisting with practical needs, supports and decision-making. And the final component is around medical and physical health services. Medical services by GPs or psychiatrists, access to nurse practitioners or mental health nurses to support with metabolic screening, physical health needs, access to telepsychiatry services, warm referrals to GPs in local community where consumers have identified having a regular GP. I'll move on now to the tender approach. Applicants can apply for either one hub or to deliver both hubs. We expect that single provider applications are presented with partnership approaches or a consortium approach with a lead agency. Successful applicants must build and maintain strong partnerships with local communities. In terms of the funding that's being made available, there'll be 1.2 million per hub to establish the service, and then ongoing funds of over 3.1 million per annum per hub. The funding for the establishment will be made available on contract execution for the establishment period from 1 January to 30 June next year. The ongoing service delivery funding, which will be available from 1 July 2026, is to the value of over 3.1 million, and there is the capacity to bring forward 10% to 1 April 2026 for recruitment, salaries and staff training. The activity has been budgeted and approved by the Department of Disability, Health and Ageing, and Central and Eastern Sydney is now awaiting confirmation of funding schedules from the department for the 27 to 28 financial year onwards. Upon receipt of confirmation from the Department of Health, Disability and Ageing, contract extensions will be offered. In terms of locations, we have shared a map, a visual of the proposed locations for these two hubs. Noting that where we have identified these locations is not the exact spot that we expect these locations, but they are the primary transport hubs within that catchment area. So the two areas that we expect to see these hubs established are Sutherland and the Inner South Corridor along the T4 train line. Now, these locations are based on population data indicators showing high relative need combined with evidence of community support and existing service gaps. Hubs must be fully accessible for people of all abilities and convenient public transport links with adequate parking facilities. Spaces should provide a calm, safe, friendly and welcoming atmosphere to all consumers. The methods that we have used to select the locations are based on several factors, and a weighted ranking was given to SA3s based on a number of variables that included CESPHN scores, growth rates, rate of PHN commissioned mental health services per 100,000 people, the percentage of called population, mental health indices, mental health prescriptions, rate of psychologists, mental health hospitalizations, Medicare mental health services, mental health ED presentations, and the proportion of population that identifies as Aboriginal and Torres Strait Islander. Considerations were also given to the spread of services across the region and public transport connectivity. The Inner South region, which has been selected, is a cluster of areas that ranked highly and was identified from the inner city to the inner west SA3 of Kogarah, Rockdale region. For these, considerations were given to distance from the Canterbury Medicare Mental Health Centre, as well as transport accessibility. The areas around Sydenham and Walleye Creek stations are particularly identified as useful transport junctions that will be ideal locations. As there is limited commercial retail space available around Sydenham, and to a lesser extent Walleye Creek, the railway corridor from Sydenham to Rockdale Kogarah, to provide flexibility of finding a location with good connectivity to maximum potential access of services, is also being considered. These regions also have low socioeconomic status, high proportion of called population, limited mental health services, and high population of growth rates. The Sutherland region was also determined as a location. This location also provides access to residents in the Sutherland Shire area across both Sutherland, Menai, Heathcote, Cronulla, Miranda, and Caringbah, who have significant distance from the Canterbury Medicare Mental Health Centre and the proposed inner south location. This area also has low availability of psychologists and use of the Medicare mental health services, despite high rates of self-identification of mental health needs in the census and high rates of prescription, suggesting potential unmet needs of services. Central and Eastern Sydney's service utilisation data shows that telehealth is used for around 60% of service contacts across programs that have similar client presentations. Provision of telehealth, where appropriate and desired by the client, will increase the reach of this service and will be included as a requirement in the model of care. PHN data also indicates that many of the mental health services being delivered by our community service providers or commission service providers are often delivered in community settings as an outreach function. For this reason, we are also expecting that the model incorporates the option for provision of care. Client choice will be prioritised in determining whether telehealth, outreach, or on-site services are provided. Hubs should incorporate digital infrastructure to support telehealth services and engagement. Hubs must all meet the relevant health, safety, and regulatory requirements. Locations should foster collaboration with local service providers and community groups to improve engagement and sustainability. And hubs should be flexible, multi-purpose areas to accommodate the range of service components to be delivered. Moving on to the workforce. The workforce should be a multidisciplinary, collaborative team working across the various service components. The workforce should be made up of a mix of new graduates, early career, and experienced professionals. The workforce should include both clinical and non-clinical staff. The workforce should also reflect the cultural diversity of the community it will serve, and the workforce may include visiting clinicians and co-located services and activities. In terms of outcomes and impact, the hub should achieve a range of outcomes, including short, medium, and long-term impacts, which will lead to changes in the individual, community, and system level. The hub should achieve the following community outcomes: improved access to mental health services, improved mental health wellbeing and quality of life of consumers accessing the service, more positive experience of obtaining mental health supports, increased connection to community and support networks, and more efficient use of resources through system integration. That's the end of the formal presentation. I'll now open up the question and answer session. Please type your questions in the Q&A box. If you see a question that you would like answered, please upvote. It will also ensure that we prioritise a response. We will do our best to get to all the questions today, and that we will ensure that all the responses from today's session will be shared via the TenderLink forum. So if I'm unable to answer a question today, answers will be provided via the TenderLink forum, and all questions I do answer today will also be included in the TenderLink forum responses to ensure transparency and fairness. Further questions can also be submitted via the TenderLink forum until the 9th of October. We'll endeavour to respond to questions as we receive them, and we will ensure that all questions are available in the TenderLink forum. So all responses to the questions will be available in the TenderLink forum by the 16th of October. Thank you, and I'll now open up to questions in the chat. Okay, I'll start with the first question. Will these clinics be expected to be bulk billed? Yes, they will be. So these clinics or these services will be free to anybody that access the service. The next question is the tender suitable for design and construction companies that provide clinical fit out, or is it just for medical practitioners? I'm not quite sure what the question relates to. Are we talking about the fit out, or are we talking about who can apply for the tender? If that anonymous attendee can please clarify. The next question is, can you please explain whether these two hubs are in addition to the current primary integrated care supports or the redesign of the PICS program? I can answer that this service is an additional service in our service system and will complement some of the existing programs in our region. The next question is, will size of the clinic, number of rooms, clinicians be determined factors in awarding the tender? The size of the clinic. Again, just for that question, I probably need a bit more context. The tender will be awarded based on the tender questions and the responses to those questions, the workforce, and suitable locations. If you're applying for both hubs, does the applicant get an increased word limit to allow the ability to answer unique needs of each community region? We have given a limit on each of the questions. They are a guide. We do expect people to stick within that word limit because you can appreciate the number of questions that we do need to evaluate. But there will be some flexibility to accommodate where there is the response for multiple hubs. I'll go back to the question that was in relation to the size of the space, if I understood it correctly. The size needs to be able to accommodate all the services required to deliver the hub services. Hope that answers that question. There is a question about if I'm able to share the PowerPoint slides. Yes, they'll be made available in TenderLink, as will the recording. Sorry, I need to keep up. Sorry, guys, there's so many questions here. And next question is, the service model guidance notes that a number of service components may be resourced through the existing funded programs. Can the PHN confirm which existing funded programs will be continuing in the region and are not and will be consolidated into the hubs for the purpose of mapping service connections and workforce planning? That question, I believe, was already asked in the tender portal, so we have already provided a response. So the idea is to work with as many of the existing programs within the region to think about co-locations or those direct warm handovers and referral pathways, but also ensuring that the service hubs themselves have all components of the model of care incorporated in their service delivery. The next question is around what would be the volume of service or activity per annum that is expected for each hub. the number of clients, sessions, and billing. We are actually asking the providers to provide their modelling around the number of people and the session activity that can be delivered as part of the model of care. That includes the funding that's available and any potential funding through alternative funding streams. There is a question around, is there an expectation about the number of clinicians and services that are to be provided over that time period? Again, just ensure that you refer to page 18 of the service documents around the workforce functions, and in the tender documents on page 6 around the workforce characteristics. That is an outline of the types of clinicians and the types of services that we expect to see within the hubs. And based on that information is what we are expecting the response and the applicants to be able to tell us about who they'll engage in this model of care and the number of both clinical, non-clinical staff and the FTE equivalents, as well as obviously the budget that reflects that. I've got a clarification for the question. Can companies apply for this tender to work in tandem with the parties awarded to design, the build and the hub? I may have to take that question on notice and will provide a written response. Do people need Medicare status to access services? No, they will not. Just having a look at what questions I may have missed. I'm relying on the team to just indicate when I've answered questions. So to be clear.
Yeah, that's fine.
I don't know what the question was before.
Sorry, I think that's the one that you said you get back to them with more detail. Yeah. So
Okay, I've already responded. Just bear with us, guys, while I look through the questions.
workforce.
Okay. Can you provide a bit more detail on expected workforce? Will psychiatrists be expected to be part of the hub model, or will there be a hub leader? Access to psychiatrists will be expected as part of the model of care, but we don't expect that needs to be funded using the hub funding. That could be incorporated into the funding model, or it could be by having pathways to psychiatry supports. Will funding be delivered as a lump sum at the beginning of the funding period, or will it be available to draw down as needed? Funding will be available upon execution of the contract and then paid incrementally, but usually payments in advance. And the incremental payments are made against deliverables. In relation to family services, would it be possible to support children if they are attending with parents, parents being the main client? We expect that this service is to be made available to those over the age of 18. In the event that there are children that need to be supported, we expect the hub to be linking those children to more appropriate supports that are relevant to that young person. Will the service be able to access remuneration via existing Medicare schemes, such as Medicare mental health items for psychiatry? Yes, they will be, but just keeping in mind that there'll be no opportunity to use both the existing hub funding as well as the Medicare item numbers. It will be two exclusive funding pools. Some of the services that are closing to fund the integrated hubs currently provide services across the PHN region. What will happen to those consumers who are currently being supported by those programs that fit outside the geographical region of the new hubs? So in response to that, anybody that is with an existing program that will be changing from the 30th of June next year will be supported to ensure they have ongoing care, either within our region or supported to access supports closer to their own homes or where they work. So we'll ensure that all people are supported moving forward, and where possible, ensure there are nobody falls through the gaps. So there is a question, you have asked to estimate number of clients with estimate occasions of service. It is difficult to summarize given the IRDST levels and requirements for each client. Are we able to break this down as an estimate per IR level? Yes, I believe that would be a good way to present that information. Are new clinics, not yet established, eligible for this process, or does the tender require the clinic to be an existing clinic? We expect that these are newly established services. If the question is about repurposing an existing facility, that is also something that we can consider. The next question is criterion 2B asks for solutions for an after-hours support. Can you provide clarity around the expectation for hub supports after business hours and particularly on weekends? We do expect providers to be able to present some options around how after-hours supports can be provided. So we are, again, expecting applicants to be able to provide those in their tender. And there are a number of options that we are currently seeing that are available that could be incorporated into the model of care. Regarding my earlier question regarding claiming Medicare items for psychology, psychiatry, and other items, can you explain your earlier response in more detail? So basically, if there is a GP or a psychiatrist that is being co-located or providing services within the hub, we can't pay for those services using both the Medicare funding and the funding provided by the PHN. It is one or the other. So there is no double dipping, if that makes sense. They can be claiming Medicare items exclusively, or they can be paid through the funding that's being made available. Will the hub model include outreach or home visits? We expect that there will be an outreach component to the service delivery. Another question, just to go back on the occasion of service, this is in the budget as one line item. Are you able to add lines to the budget? Value of occasion of service will differ depending on IR rating. Yes, absolutely. You can add line items to the budget, and you can add any appropriate line items that you feel we need to know about in your budget that is being presented. If a provider claims through Medicare exclusively, will they have to bulk bill or can they claim a gap payment? They will need to bulk bill. These services will be delivered free of charge to anybody that presents. Will the hub allow telehealth remote clinicians to provide treatment to patients who attend the hub? Example, hubs could facilitate a video conferencing telehealth appointment. Yes, that is permissible under the model of care. I don't believe we have any more questions, but I'll give everyone 1 or 2 more minutes before I close off. And I will remind everyone that we will provide written responses to all the questions that I have answered today. And where required, I will add a bit more context. And I'll also remind everybody that you do have more time to submit your questions via TenderLink, which we'll respond to as quickly as possible. And just wait on 1 more minute to see if there's any more questions in this session. Yeah, will the successful applicant be announced publicly? Yes, once the contracts are executed, the successful applicant or applicants will be announced publicly. All right, thank you all for your time today. Oh, one more question. Can an additional service be provided at the clinic that may be eligible for Medicare or the PHN funding? For example, services that may be out of pocket, example, naturopath, Chinese medicine, and other modalities. I suggest that you incorporate that into your application and it will be considered. All right, unless there are any more questions, I will close the session for today and thank you everybody for your time.